monitor. Oh, it's the front one. Works okay.
Do you want the mic, Kako? Do you want this?
Rolling in or off. I'm going to do a small thing using this one.
It's on already. Okay, that's
So, because if not, you have to take it off, put it in, and it's a bit stressful for just 2 minutes.
okay.
Aaron? Bruno. Hi. Meet you. Let's get started.
Ready to go?
Yeah. All right, we'll be starting with the next symposium.
Hello. Good morning to everybody. So we're going to do this symposium of quantifying consciousness. We are very thankful for the organizers for putting this very nice meeting, Bruno, Olivia, also the scientific committee for inviting us. And the way it's going to work is that Aaron is going to do first a few introductory remarks, and then he's going to give his talk. And then we have time for one or maybe two questions at the most for each individual talks. But then at the end of the whole symposium, we're going to have a 10 to 15 minutes for sort of a plenary talk. So Aaron is first, and then Marcello, then I present my data, and then Anil is going to give his data and some conclusion remarks. Thank you.
Can you hear me okay? Yeah, okay, good. So what we're about here is trying to understand consciousness and how consciousness manifests in the brain. And one of the best ways to convince ourselves that we're starting to understand consciousness is that we can do something. We can, for example, look only at someone's brain activity and ascertain whether or not they're conscious of a certain piece of sensory information. Or, and more pertinent to the symposium here, we can just look at somebody's brain activity and ascertain whether or not that person is in a conscious state. In this case, it's trivially easy because you can see that this brain is kind of glowing, so we know that this guy's conscious. But for the standard garden variety, non-glowing kind of brain, that's a lot harder to do. So this points out these two sort of parallel streams in consciousness research. One has to do with picking out conscious perception, whether or not someone is perceiving a given piece of sensory information. So here, I've sort of operationally defined that as the question of whether or not some nugget of information is encoded or processed in such a way that it becomes part of what you're conscious of. And this other sort of stream of research is about conscious state, whether or not the brain as a whole is in a state that supports this kind of information processing. If you're in a coma, no, probably not. If you're in deep sleep, probably not. If you're awake and alert, almost certainly yes. After 12 hours of jet lag, who knows? So the theme of our symposium is this subject of signatures of consciousness, the idea of trying to move towards something that is not only sensitive to consciousness, but also has high positive predictive value. It's selective as well. So we're going to call a signature some sort of a metric or measure that can detect a conscious state or a conscious perceptual event. So an example that's floating around in the air is Tononi's phi. That one's very hard in practical terms to compute, but it's an example. Another feature that qualifies as signature is that it can do this for a single instance. So that would be for like an individual person, an individual brain. Is that brain in a conscious state? Rather than saying, on average, when I look at many brains that are in a conscious state, I see this. Or for an individual trial, I look at an individual exposure to a stimulus, and I try to ascertain whether or not on that instance, that individual was conscious of the stimulus. So moving in this direction, I think the field has started to make a really quantum leap in terms of what we are capable of doing based on our understanding of consciousness. We've reached the point where, according to the title of one recent article, we can quantify the unquantifiable. We can, to some degree, to a reasonably high degree, ascertain whether or not a patient who's unable to communicate is in a conscious state or not, and ascertain the likelihood that that patient may or may not recover consciousness in the future, which is dreadfully important to people who are confronted with this situation, and in particular the family members. We have a dear friend whose son was recently struck by a car and has been in a coma for some months. And I can tell you from personal experience, it's extremely difficult, especially for the family, to know what to do. And the thing that they want to know most is he still there? Is he going to come back? So there are a couple of different approaches to quantifying conscious state. One is indirect. If you have a signature of conscious perception and you're confident that it works pretty well, then if you detect that signature, then you can infer that brain must be in a conscious state. And I take up that approach. Hako also takes that approach. There's a more direct approach to measuring conscious state, which is if you have some hypothesis as to what kind of functional properties are necessary for the brain to support consciousness, you can just try and measure those directly. Marcello takes up that approach, Hako as well, and also Anil. So ultimately, a good theory of consciousness has to take account of both of these, both the idea of conscious perception, conscious content, if you will, and the conscious state. And I think that this debate or this dialogue about trying to measure consciousness, both in individual instances and more importantly in individual brains, is sort of fertile ground for trying to bring these two together towards refining our theories or coming up with a unified theories that accounts for both. So I'm just going to end here these opening remarks with a few caveats and tough questions that I think it would be a good idea to keep in mind throughout the talks and that maybe we'll come back to at the end. One is, how do we know whether a given signature is specific to consciousness rather than just a general signature of normal brain function? Right? It could just be that what we have is a signature of a brain that's just functioning well. Not only does it support consciousness, but it enables you to add 2 and 2, and it enables you to recognize faces and so on. If your signature is predicted by more than one theory, is it still meaningful to say that the development of that signature was theory-driven? This is going to come up. I mean, I even think that my signatures that I've been working on are theory-driven. But then I wonder about this. What do we learn about consciousness from the fact that seemingly very different metrics all appear to be measuring the same thing? I think that's a particularly interesting question that we can use as, again, fertile ground among these 4 talks. And does fidelity to a theory imply a better signature, necessarily, even if the theory is right? So as Hako said, here's the quick program. I'm going to present some of my recent data on using stability as a signature of consciousness. Then Marcello is going to talk about complexity, Hako about information exchange, and then Seth is going to wrap up with some more theoretical remarks and really constructive, hopefully, criticism, and some data of his own. And then we'll conclude with some time for general discussion. So I'm going to go straight into this work that I've been doing over the past few years, largely with Stan DeHaan, but also with a lot of help from Ioannis, and more recently with Hako and Lionel, as well as I've brought the patient data into this study. And this really started with my interest in recurrent network models as a good metaphor, or even more than a good metaphor, as models for how perception works. This is a simple recurrent network, and it has this pattern stored in it that I've highlighted with these yellow circles. And if you impose an initial noisy pattern on it that bears only the faintest semblance to the stored pattern, because of the way these units are connected to one another, if you just leave it to its own devices, it eventually settles on the stored pattern. I think you can see how this can be a very good model for perception. For example, the processes that allow you to recognize that this is a face in spite of the fact that there's very little information present, and the information that's there is highly degraded. One way of thinking about this kind of process, what I just showed you in the little video, so the evolution of the state of that recurrent network, the state is like this ball, and it's rolling around on the landscape, and it rolls around until it falls into a little basin, and that's its decision. So how do you know that it's decided something? because it's passing through all these different states, right? Any one of these could be the decision. The way you know it's the decision state is because it kind of stays there for a little while, at least until the landscape changes, right? So testing some predictions that come up from this model. I think these are the 4 main predictions that come out of it, and these are the ones that I've really been I've been after. Presented with the same input, the network consistently converges towards the same final state. So that means that on repeated presentations of the same stimulus, you should get a reproducible pattern of neural activity. So I call that reproducibility. And once converged, the pattern of activity is relatively stable. Again, at least until the landscape changes. And so that's this notion of stability that I'm going to focus on. The amount of free energy, so the amount of net activity, can actually be lower when the network reaches its decision state. That's a bit counterintuitive, but an interesting prediction. Although I'm not going to go into this one today, this kind of process is slower than feed-forward decisions, which are very fast, the kind of decisions that make you respond when you see a scary thing like a snake. So a few years back, I started with predicting this prediction about reproducibility. So we used fMRI. We looked at patterns of activity in the temporal lobes in response to stimuli, near-threshold stimuli that we were either seen or unseen. And what we found is thanks to actually Schwarzkopf and Rees actually were criticizing our finding, but they made this really great graphic that actually illustrates what we were trying to show. I think the pointer doesn't work. Yeah, so that when the stimulus is visible, the pattern of neural activity, which in their world is the British flag, are more similar to each other across trials than when the stimulus is invisible. So there's still information here about the stimulus, but it's less reproducible. Okay? And that's, in fact, what we found to be the case. So this measure here, which is actually lower for visible stimulation, for visible stimuli, is a measure of variability. So lower means it's more reproducible across trials. So some other research that's tested this kind of prediction in practice comes from Churchland, and while in the lab of Krishna Shenoy at Stanford. What he's looking at is the idea that when a stimulus impinges on the sensory system, it tends to draw the brain, or the state of the brain, consistently towards the same region of state space. For putting that in plain English, if you're looking at the pre-target period, there are a lot of different states you can be in when you're not processing the stimulus and you're just waiting for it to appear on the screen, right? So this is a sort of 2D projection of the state of a population of neurons. But as soon as the stimulus appears, the state of this system starts to be drawn, the state across these different trials starts to become clustered in the same region. Another way of looking at that from the point of view of a single neuron is just to show that when the stimulus appears, variability in the firing rate across trials, which you can see here are the gray lines are the individual trials. After the stimulus appears, the net activity goes up, but I think you can see that the variability goes down. And that's here. So the variance across trials precipitously drops when the stimulus appears. Well, the mean sort of goes up. And he used a procedure for controlling for the increase in the mean, for those of you who might be concerned that that is an artifact. And this basic phenomenon manifests across all different areas of monkey cortex in response to different kinds of stimuli. You find it also in cat cortex. This is actually from the cat as well. So it seems to be a very general phenomenon. So the caveat here that I'll point out is that in order for this reduction in variability across trials, or in order for a reduction in variability to be relevant for perception, it has to be realized within trial, right? You can't say, well, I'm not sure I've perceived that thing yet. I have to wait for the next trial, and then I'll tell you, right? So that means that it has to be stable across a small interval of time within trial, if this model is correct. And in fact, if a pattern of activity is stable within trials, that necessarily predicts that it will be reproducible across trials. Well, you'll just have to take my word for it on that one. So the predictions here in the research that I've been carrying out are these, that you'll find reduced variability across trials, reproducibility, much like Churchland found, and as we've found previously in fMRI data, reduced variability within trial, stability, and both of these will diverge later in time depending on whether a threshold level stimulus is seen. Because when it's consciously seen, the system has settled into a special kind of decision state where it's certain about the quality of the stimulus. So the data that I've been working with, really high quality simultaneous EEG, MEG data recorded at the Neurospin Research Center. So we have 60-channel EEG simultaneously recorded with 306-channel MEG data, which includes 102 magnetometers. They measure the ambient magnetic field strength, and 204 gradiometers that measure the local magnetic field gradient. And so I've focused my analyses on these primarily because they have particularly high spatial resolution. So how do we measure stability? The way I've approached it is to look at these data samples. So these are different sensors. I have lots of them. And each bar here is a single time sample. So I treat the pattern across the sensor array at that time sample just as a vector in a high-dimensional space. So this is just a three-dimensional space. You can imagine that this could go up into a much higher dimensional space. And these are different time points. And so the vector moves around across time. And the question is, what's the degree to which these vectors are all pointing in the same direction? So if the pattern is relatively stable over time, then the vectors across different time instances will tend to be mostly pointing in the same direction. And this dispersion here that I've highlighted with the circle will be greater or smaller, right? And at the same time, we also measure just the magnitude of the vectors. Although in measuring the dispersion, I want to point out that it's independent of the magnitude. We measure this after factoring the magnitude out. So the question becomes the degree to which these vector angles across time are more disperse or less disperse. If they're less disperse, then that means that the pattern of activity is kind of stable over that window of time. We can use the exact same math to compute reproducibility, except now instead of these being different time points, they're the same time point but in different trials. And we can use this to measure reproducibility, the degree to which this thing is dispersed across trials. This corresponds more to what Churchland was looking at in single unit recordings, except it's sort of a multi-dimensional version of that. So the stimuli I've worked with, I'm not going to go into too much detail about that, but I use something similar to what was presented yesterday. I have face and house stimuli presented in opposing colors. When presented separately to the two eyes, they tend to fuse. And depending on the color contrast, the resulting percept is kind of like just this yellow square. And below a threshold level of color contrast, really you just see a yellow square. But when it's right at threshold, when the color contrast is right at threshold, which we determine for every subject, then sometimes you kind of think you see it. Sometimes you're not so sure. So that's what we use in these experiments. We have the physical properties of the stimuli are fixed, and we asked subjects on each trial whether or not they saw it. And we also have these blank control stimuli. There is no stimulus at all. They just give you the yellow square. So when we look at some of the standard correlates, we reproduce pretty well what's already been shown in the literature. So if you look here, this is on the top, the evoked potential from this PZ electrode in the EEG. And it's been low-pass filtered a bit, so some of these faster components you don't see. But I'm highlighting this sort of late positive component here, often called the P300, although some people don't like to call it that here because this is like 500 milliseconds. And this is the difference wave. So this is the difference between the evoked potential for objects and the blank control stimuli. So here what you see is just that this late positive wave is significantly bigger for seen compared to unseen stimuli. Looking at the time frequency decomposition, this is another sort of well-documented property of seen versus unseen stimuli. You tend to have an increase in gamma activity and a suppression in the alpha and beta range. And we find that to be true as well in our data. This is from the MEG data. You also can find this pattern in some of the EEG sensors. So now turning to this measure of stability. Sorry, reproducibility. So we'll start looking across trials. So when we look at this across-trial measure of angular dispersion, which I call DVA, which stands for dispersion of vector angles, what you can see is I'm missing the time axis here, but this is 0, and this is 500 milliseconds out here. You'll have the time axis in a minute, actually. You see that right at the time of stimulus onset, a cross-trial variability drops dramatically, just as Churchland found in single units. And again, when this drops, it means that reproducibility goes up, because this is variability. Then what's interesting is that later in time, these two diverge as predicted, depending on whether the stimulus was seen or not. And it's appreciably more reproducible when it's seen. So now I think you'll get that time axis. Yeah. And so here's the same measure, but applied in a 100 millisecond sliding window within trial. And here, this is the one that's sort of greatest interest to me, is showing that, again, in this sort of relatively late time period, stimuli that are reported as seen are associated with a period of relative stability of the pattern of activity compared to trials where the stimulus is not seen. And here, this is just the L2 norm of the vectors, just to show that there aren't any significant difference in the total power across the sensor array between those two. And if anything, the unseen one is a tiny bit higher, though not significantly different. So what about the blank control stimuli? So for a proportion of those blank control stimuli, what was interesting is because we're working at threshold, for something like, on average, 25 or 30% of the blank stimuli, subjects actually thought they saw something. And they gave an answer, face or house. So we had not a lot of those data, but enough that we could analyze them. And what's interesting there is that you get this same difference here in both reproducibility and stability, and this counterintuitive difference in the norm, where the unseen stimuli are associated during this same period of time with a higher net amount of energy across the sensor array. And you might say that this is a pure instance of conscious perception, because there was no stimulus. There was no object. It was just a blank square. So this is entirely endogenous. So now I'll move on to the patient data. So after I had been working on this for some time, I approached Taco about working with the same patient database that he was working with to try and apply this same measure to see if we could distinguish conscious state by looking for evidence of a signature of conscious perception. So this is a database. It's a growing database. At the time, 165 patients with disorders of consciousness at the Hôpital de la Salpêtrière in Paris. These have all been clinically diagnosed, so these labels were clinically assigned. There are 25 quote-unquote conscious state patients, so these are patients who've recently recovered consciousness, but still have a brain injury, right? 66 in a minimally conscious state and 74 in a vegetative state, and an additional 12 healthy control subjects. And all of these individuals are exposed to these brief trains of auditory beeps, 5 beeps, beep, 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 like beep, 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 beep. Occasionally, the last beep is different. I'm not really going to pay attention to that. I'm just looking at these beeps as a way to sort of ping the brain and look at the way the brain responds to a stimulus. And what we found, quite surprisingly, so here, this is the time of onset of the first in the series of the beep. The last in the series is out about here. So just to unpack this figure a bit, I have these two rows. So this is just the absolute value, the absolute value of the within trial angular dispersion and the norm. And then this is the relative value, where I've subtracted out the value at the very time that the stimulus train started. So what we see here is that for within trial dispersion, for stability, if you will, healthy control subjects, and parametrically down the line to vegetative patients, healthy control subjects have a higher amount of absolute variability. You could say, well, there's more interesting stuff happening, right, in general. But they have a much greater relative reduction in variability when the stimulus turns on. So this sort of inverts, right? Whereas for the absolute magnitude of the for the norm, or the total power across the EEG sensor array, this doesn't change. It's much higher for the patients, and then lower for the individuals who are in a conscious state. So I think this is particularly interesting in light of some of Marcello's work, where he's found that with the response to TMS pulses in patients, it's actually higher in amplitude in the vegetative patients than it is in the locked-in or conscious subjects. It's less interesting, in a sense. It has less information in it, but it's just higher amplitude, as if the brain is lacking some kind of lateral control that is necessary to keep the system in what Tononi refers to as a tense state. So this just summarizes a bit the patient data. Here, this is just the average angular dispersion in the sort of late period of time after the last stimulus. And you see that in absolute terms, it's going up with conscious state, but in relative terms, it's going down. So this thing is becoming more stable relative to the level of stability when the stimulus came on. Whereas the norm is just simply higher for the non-conscious patients. And then this gives you an idea of how well we can discriminate the different categories of patients based on these different, based on based on angular dispersion and the norm. So you see, we can make this all-important distinction between minimally conscious and vegetative patients much greater than chance. And of course, the distinction between conscious and vegetative is probably the strongest and the easiest to make. But we can distinguish, we can make all three comparisons much greater than chance based only on the stability. The norm, so the energy, is okay at distinguishing the conscious from the vegetative and the conscious from the minimally conscious, but it doesn't do such a good job of distinguishing the minimally conscious from the vegetative. So stability seems to be a more sensitive measure. And these are just confusion matrices where we've used a linear discriminant analysis classifier that takes into account both the change in stability, the change in dispersion, and the norm to try and classify these patients. And what you want to notice is that this is hotter along the diagonal, means that what you train it on, it tends to agree with the actual label tends to agree with the label assigned by the classifier. And more importantly, when it makes a mistake, it tends to make the mistake by assigning one of the nearby classes. And here is the confusion matrix when we just restrict the comparison just to the minimally conscious versus the vegetative patients. Okay, and I'm almost done. And then this is just this each dot here is one patient or one individual, color coded again in the same way. So these dark dots are the control, and slightly lighter are the conscious patients, and so on, the minimally conscious and the vegetative. And this is just showing these dots just in these 2 dimensions. So basically, by reducing the data to these 2 simple dimensions, by themselves carry a lot of information about the state of consciousness of the patient without any really sophisticated transformations. This is really simple vector math, right? I've just turned this into an angle and an R, or a norm. So to summarize, it looks as if the pattern of neuronal activity is more reliable or reproducible across trials when it's conscious. The pattern also appears to be more stable within trial when it's conscious. And you can use this to classify the conscious state in DOC patients. And counter to intuition, the neural response may actually be stronger when not conscious, which I think is an important finding, especially vis-a-vis the predictions that are made by the recurrent network metaphor that I presented at the beginning. So one interesting thing that I'll point out is this coming back to this question of how do I know whether this is my signature is a signature that's specific to consciousness and not just a general signature of a normally functioning brain? Well, this is how I can know. I can test my signature on healthy subjects, but on the distinction, on the divide between being conscious or not of a stimulus. And if that same signature works in both dimensions, right, distinguishing consciousness or not of a stimulus, and whether or not a patient is in a conscious state, that is at least one way of addressing that question and validating the signature. So I'd just like to acknowledge my collaborators, Ioannis, for whom I don't have a photo, or well, at least he asked me not to use that photo because I think he was like 16 years old in the photo. Stan DeHaan, Hako, of course, who you're going to hear from shortly, Lionel Nakash, who was kind enough to give me the phone number of his hairdresser. So yeah, we go see the same hairdresser. So thank you. Thank you.
Hey, can I ask a question? Aaron?
Yeah, I can hear
Yeah.
you, but I...
Hey.
Oh, there we go. Yeah.
Yeah. So if I take your suggestion seriously, and if the reproducibility or stability reflects the contents of consciousness, then in the case of a backward masking, a CFS or whatever, binocular fusion, when the subject is supposedly not seeing the stimulus, it's not really like not seeing anything, but it's rather, seeing the masked stimulus or masking stimulus, right?
Yeah.
Like in the case of CFS, invisibility of the face implies visibility of the Mondrian. Mm-hmm. So if your measure is really correct, then it means probably, if you compute this stability or reproducibility from, neuronal correlates of face or Mondrian, then those should go in the opposite direction, depending on the subject's reports. Do you see that kind of thing?
Yeah, well, okay, so that's an excellent point, an excellent question. I don't think I have, using MEG, I'm not sure at least I have the tools to be able to do that. But that would be amazing, right, if one had access to single unit data, say, in humans, and you could actually pick out the representation corresponding to one or the other stimuli, for example, then I would predict, yes, that it's not just that the whole system becomes more stable. I didn't mention that, but it wouldn't make sense for the fact that when you become conscious of a stimulus, your whole brain becomes more stable, because there's all that other stuff that you're not conscious of. So it's a kind of tug of war between some subset of the activity in your brain that becomes more stable at the expense of all the rest of the activity that's, relatively speaking, less stable, right? And so you would expect to find the content, the information that you're conscious of, to be among that activity that's relatively stable, and the information that you're not conscious of to be found among that activity that's less stable. And so if you had the tools to check that, to test that at the fine-grained level, I think that would be very, very interesting. So yeah, I agree, if I've understood you correctly. Yeah.
Stability. How different is your measure of stability within trial stability from just simply a reduction in the lower frequencies, as it is described?
So it's hard to tell those apart. But here's a simple simulation where I introduce a stable pattern. These are simulated trials with just a lot of noise. And at some point, I introduce a stable pattern, and I hold it there for a little bit of time, and then it goes away, right? And here I just apply these two measures, dispersion and norm. You see the norm doesn't change, but dispersion goes down at the time of this pattern. So here, if you just consider this to be the point, let's say I'm looking at one of these electrodes, one of these sensors, like this one right here, right? What I'm going to see in one dimension is that there'll be this level of activity that at some point goes up and then goes back down again. So if I do a frequency decomposition on this, of course, this thing has a lot of low-frequency energy. And it also has phase locking in low frequencies, right? Because of its very nature, right? Because you're only going to get a significant result here if this is sticking out from the noise enough. So if I do now a time frequency analysis on this simulated data where I don't have any oscillatory event, I don't have any oscillation, right? I still recover in the case where there's a stable pattern. I recover significant increase in low frequency power and significant increase in low frequency phase locking. So it's hard to tell the two apart. The bottom line is that a stable event necessarily carries low frequency energy.
Okay, I'm sure there are more questions, but we can continue in the general Q&A. Thank you, Aaron, once more.
Yep.
Okay, thank you. Thank you, the organizer, and especially Aaron and Jaco for putting together this symposium. I will start also by thanking all the people that contributed to the data we'll present, because this is the effort of 10 years of work in different places, Wisconsin, Liège, the Coma Science Group in Liège, and Milan. So it's really a teamwork. And I want to start by saying this. And during these 10 years, we started actually in 2004, more or less, we tried to, we applied these strange TMS-EEG measures where we perturb the brain with a magnetic pulse, and we get the EEG response of the brain in many different conditions where consciousness is present, lost, and recovered, including non-REM sleep stage 4, REM sleep, different anesthetic, propofol, xenon, midazolam, ketamine, and then we moved to patients evolving from coma towards different conditions. And the purpose of these experiments was twofold, actually. So one is to address a practical question, that is, how do we address, how do we assess the level of consciousness in subjects who are completely disconnected from the external environment on the input and output side. So this was, in a way, a practical question that we might face in the clinic. But the other reason which was actually the original reason for developing this kind of novel approach, was to test a specific prediction. And the idea to test was that consciousness is tied to a specific kind of complexity, which I will describe during my talk. So let me start by just mentioning what's the practical problem, which was already brought out by actually Aaron. This is a patient in a coma. Coma is a sleep-like state. Patient is eyes closed, but cannot be awakened, not even with painful stimuli. And it's a transient state, and if the patient doesn't die, after a few weeks, he opens his eyes. Best case scenario is that there is communication and he can signal that he's there, that he's conscious. We have no problem there. Otherwise, patient may open their eyes and show only reflexive automatic activity. So in this case, they are awake, the brainstem function is coming back, arousal is coming back, but there's no consciousness. This state of awakeness without consciousness is the vegetative state. And then there's a large gray area, which was recently identified, about 2002, minimally conscious state. These are patients which show fluctuating signs of consciousness, basically. So they can respond today, but they don't respond tomorrow to a stimuli, and they track people. Typically, they track people moving in the room with their eyes, but they cannot communicate reliably. So it's a very difficult situation, and indeed, these patients are conscious to some extent. We don't know what they are conscious of, whether they are fully conscious as we are, whether they're dreaming, hallucinating, or just in a state similar to light sedation. We cannot know that, but we know they are conscious to some extent, and they have a better prognosis. So it is important to detect them. Problem is that there is a big clinical error here when we base our judgment on behavior. This 40% is maybe an overestimation. If we use the appropriate scale and we do it repetitively it goes down, but still it is an error. So where is this error coming from? We normally, in the clinic, treat the brain as a black box, and we work on input-output relationship when assessing consciousness. So we give stimuli, and we observe motor response. If the response is appropriate, specific, we say the subject is conscious. Otherwise, we say is vegetative. But it might be well the case that the subject is fully conscious but fully paralyzed. This is the complete locked-in syndrome. It's a classic example. So in this case, we would have a false negative at the bedside. So there are ways to get around this complete blockage of motor output. One way to go around this is to measure, to give stimuli or commands to the patient and measure directly brain activity, neuronal activity. And this is the famous active paradigm developed by Owen. I won't describe this because you all know this. You ask the patient to imagine to play tennis or walk in his own room, in his own house, and you see specific pattern of activation. You take this as a specific motor output. It's just the same, and it's very specific. Problem is, can we use this to detect consciousness with high sensitivity, to make sure we don't miss a subject? No, because the same authors show that this approach often doesn't work in subjects who are conscious, brain-injured subjects who are conscious. Like in the paper by Monti, which followed this paper, out of 31 minimally conscious patients, only 30 were able to perform the task. So it's a very low sensitivity. Why is that? Probably because it requires a lot. So the patient needs to understand, needs to have working memory, attention, concentrate on that particular stimulant, and executive function. And this is not a given in brain-injured patients. Most fundamentally, it requires that sensory inputs and sensory pathways are intact and sensory processing is there. And again, this is not a given in brain-injured patients. And maybe for similar reasons, also event-related potential like the P3B, and maybe Jaco will show that, as high specificity but low sensitivity. So it can be absent in brain-injured conscious patients. So how do we go around this? I mean, the problem is, after all, that we work on input-output relationship while we know that consciousness can be generated entirely within the brain without exchange of information with the external environment. We do this every night when we are into REM sleep, and an extreme case is ketamine, where we are completely disconnected from the external environment, input and output side. We can have surgery and vivid experiences, sometimes crazy, but these are experiences. So the principle here is that we need to develop a way to assess the level of consciousness directly based on brain activity if we want to gain sensitivity. So what do we measure? It is not easy, because ideally, again, we should find an index that is both specific and sensitive, and it's not trivial, because we have many candidates that correlates with the level of consciousness on average, but we still don't have a single measure or a combination of measures so far, which are able to detect or distinguish between conscious and unconscious subject in many different conditions, physiological, pharmacological, and pathological. So this is a challenge. So what do we measure? It's not easy because, for instance, levels of brain activity, we could take that as a candidate and it correlates sometimes, but sometimes it doesn't. In sleep, for instance, consciousness is gone, sleep stage 4, and levels of neuronal firing are not decreased significantly. Again, even more so, epilepsy, you can have increase in neuronal firing, big spread of activity, and loss of consciousness. We've seen it yesterday with Oral Blumenfield. Synchrony, it correlates. You know, it's a good candidate. Still, synchrony can increase in conditions where consciousness is lost, including seizures and propofol anesthesia, for instance. And then also measures that are based on spectral entropy, entropy of spectral feature. These are the measures that are, you know, on which the bispectral index, for instance, is relying, used by anesthesiologists. I mean, also, these kind of measures are not reliable at the single subject level in different conditions. So, based on empirical data, it is difficult to say and it's difficult to choose. So that's why we stepped back and we took a theoretical perspective. And we started from the integration information theory of consciousness, which starts from phenomenology and postulates that consciousness requires an optimal balance between integration and differentiation in thalamocortical circuits. So for short, I will call this complexity. But by complexity, I mean this. And these are very trivial examples of what it means by integration and differentiation using this very simple system. So this is a system which is surely differentiated, but is not integrated. It's a modular system. On the other end of the spectrum, we have a system like this, which is fully integrated because of this homogeneous connection, but it is not differentiated. There are not many degrees of freedom here. And this is a balanced system, a system with a conjoined presence of integration and differentiation. And this is what we call complexity. Problem is, how do we assess this kind of complexity? So there is a theoretical measure proposed by the theory, which for now is not applicable to real brain. It can be applied only to simulated system or to simple system for the moment. So we need to approximate that somehow in a very coarse manner. And one way to do so is to perturb the system and measure the response of the system. It's a causal measure. So it's not enough to observe. And why do we take this way? Because if you do this in a modular system, a system that is not integrated, you're going to have a local response. If you perturb a system that is integrated but has lost differentiation, you will have a global response, yes, but this response is going to be simple and stereotypical, easy to describe, only in a system that is balanced, that is integrated and differentiated at the same time. You're going to have a spatio-temporal pattern that is both global and differentiated. And this is what we mean by complex. So this is roughly what we will try to measure. Problem is that it is not easy in the human brain because we need to perturb directly the cortical system, bypass sensory and motor pathways, so on and so forth. So one way to do so, and this is why we resort to TMS-EEG, is to use a magnetic pulse, which lasts for a fraction of a second, which activates a patch cortical neuron, so it's a local activation, and then high-density EEG. It's a specific EEG which is compatible with TMS. This is technically challenging. And then there is a navigation system to make sure you're reproducible and so on and so forth. But these are technical details. The point is here is that we hit the brain, we engage a causal relationship, and then we observe the complexity of these causal interactions. So the complexity of deterministic interaction of the brain. Practically speaking, these are cortical-cortical evoked potentials. Then, once we have this measure to approximate our hypothesis, or to test our hypothesis, we need some models. So we started from sleep, which is a very familiar model where consciousness is lost in stage 4 and then recovered during REM sleep. How do we know? We ask the subject upon awakening based on a delayed report. In wakefulness, we know the subject is conscious because it's telling us. And the same applies to anesthesia, which is a little bit better controllable than sleep. We can ask the subject upon awakening, were you experiencing something, or was it anything going on to your mind? And we tried midazolam, propofol, and xenon, and then we moved to unknown fields, that is, brain injury patient. We can assess them clinically, but we don't know really well. We cannot trust, the behavioral science of consciousness there. So this is more like, making inferences. So let me start with sleep. I won't go into the details of the experiment procedure, straight to the data. So we zap the brain with TMS, and this is the response. So it's a distributed response, which involves different electrodes integrated and differentiated. There's a complex spatial-temporal dynamics, and this is shown here by looking at the dynamic of cortical activations during wakefulness. So you see it's a response lasting for 300 milliseconds where activity is propagating in the brain in a kind of specific and global way at the same time. And we can summarize this pattern more or less like this. I will stop it now, but it lasts for 300 milliseconds. So something like this. Latency is color-coded. These are significant activation on cortical surface. Sleep, very different pattern. So as Aaron was pointing out, this is an unconscious state. The response is though bigger. You have a bigger response. It's a big positive negative wave, which though doesn't spread too much to other sensors or cortical areas, as you can see here from the source modeling. So the center of mass of neuron activity is local. It stays there, as if the system is kind of modular. So this is what we see so far in very descriptive qualitative terms. The system is responding a little bit like this in this case and like this in this case. But one could say, okay, during sleep, neurons are hyperpolarized, and you just need to push a little bit harder with TMS, and you're going to overcome this breakdown of integration. So we tried that, and the only result you can obtain by increasing stimulation intensity progressively is to trigger a progressively bigger, slow, stereotypical wave. It's a positive, negative wave that gets bigger and spreads like an oil spot on the cortical surface. So there's no way in between and no chance of having a complex response. It is either local or global, but simple and stereotypical. Again, this is qualitative. What about anesthesia? Different way to induce unconsciousness, pharmacological, and there are different anesthetics out there. So we tried first midazolam, which is GABAergic. Then we moved to propofol and xenon. The end point is always the same. It's a big up and down, which can be either local or global, depending on stimulation intensity or the kind of anesthetic you use. For instance, in xenon, you have a bigger wave, which spreads in a stereotypical way, while in propofol, you have a prevalent breakdown of integration. It's a small up and down that remains local. But in all cases, the end point is the same. No integration or no differentiation. Well, I don't have a slide about REM sleep because I forgot it, but in REM sleep, the response goes back to be complex. So you have widespread and differentiated response. Sorry about this. Now, we move to patients. So, briefly, these are vegetative state patients, subset of vegetative state patients. What kind of response we have? It's just the same response as we would have in sleeping or an exercise subject. So provided we hit healthy portion of the brain, we have this interesting up and down. And this is interesting because we know, or we can investigate at least, what is the mechanism of this big wave in sleep. I won't go into this. This would be another talk, but it's bistability in cortical neurons. And this can be due to increased potassium currents or increased inhibition. There are different mechanisms there that might play a role, not only in sleep, not only in anesthesia, but also in brain lesions. So this is an important mechanistic insight to understand what happens and a possible way to study. The only exception is post-anoxic patient. They have, most of cortical neurons are dead, so you don't have any response to TMS. Locked-in patients, fully paralyzed but fully conscious, responses just like in awake conscious patients. And the interesting thing is that if we look qualitatively at minimally conscious patients, the one that we have hard time distinguishing on a clinical basis, their response is indeed different. And you can see it on the screen when you run the experiment on a single subject basis. So this is, again, interesting, but it's all qualitative. Actually, I just want to show here that you can also kind of follow the recovery of consciousness by looking at these responses. So this is a patient who's vegetative at the beginning. She's still vegetative 7 days later, but complexity is coming back, and then she recovers communication, and she emerges from the minimally conscious state. She's able to communicate reliably. But this is all qualitative. Let me summarize what we saw so far. So in different conditions where conscious is absent, we either have a local response, looking like a little bit like this, or a global stereotypical wave that invades the whole cortex, like in an homogeneous system. This is what we found across these conditions. And when consciousness is present, in wakefulness, dreaming, but also in conditions where consciousness is difficult to assess because it's disconnected. You can have it only on a delayed report or by assessing the patients with a coma recovery scale. You have this complex, widespread, and differentiated response. Okay, we need to come up with some numbers and quantification because this is all, it's just a description. So what we did is we came up with an index that tries to capture in a theory-driven way, and I want to stress this, and we can discuss whether this is specific or not, this balance between integration and differentiation. The idea is that first we zap the brain with TMS, then we perform non-parametric statistics to detect the deterministic activation, the causal activation, which were engaged by the perturbation over across trials. And then we binarize the spatiotemporal matrix, and we come up with a binary matrix, just like a file. And the idea is that we zip the file, and we come up with an index of compressibility. The more compressible is the file, the less complex is the response, and vice versa. The idea is that if the system is not integrated, you're going to have a local response, easy to compress, small matrix. If the system is integrated but lacks differentiation, you'll have a response that is large, widespread, big ignition of activity, but there is redundancy in there. So it's easy to compress. You don't need many bits, and you will need information. You cannot compress. Instead, a response that is both widespread and complex, the one that is generated by this causal interaction in the system that is balanced between integration and differentiation. So this is the idea. We tested it empirically, first in awake subject. This is crucial. You need to demonstrate that this PCI, perturbation complex, is always high in a subject who's healthy, awake, and conscious, and it tells you he's conscious. So we probe different areas, parietal and frontal, at different intensities, and complexity is always there, around 0.6. And it drops only when the subject falls asleep, when he's anesthetized with midazolam, when he's anesthetized with xenon, or with propofol. So in this way, we obtain these two distributions. One is for consciousness. We know that they are conscious because they tell us. And one is for unconscious, sleep or anesthesia. We know that we're unconscious because they tell us. Best of our knowledge, this is the best we can get, actually, the report, a delayed report. But it's a reference scale. Then we tested for, we wanted to see whether the measure is somehow graded. And indeed, in propofol anesthesia, when you keep your patient with an infusion pump at level 3, this PCI is at the intermediate level. So at least at this course level, there is some graduality, as well as in between in stage 1, but goes up in REM. And then we move to patients. So the idea here is that we have a measure. We tested it in conditions that are known, and we come up with a distribution. In this case, you would have 100% specificity, 100% sensitivity, because you have a clear-cut separation between the two conditions, conscious and unconscious. Where are patients? So we have 68 patients for the moment, not many, but we are collecting more. These are conscious patients, brain injury conscious patients. The red ones are locked in, fully paralyzed, fully conscious. This is severe brain injury. So these are patients who have big brain injury, they recovered consciousness, they recovered communication, so they're fully conscious. And these are minimally conscious patients. These patients, they have been evaluated several times. So these are including fluctuating minimally conscious patients, meaning that the PCI in these patients is very sensitive because we don't miss one. They are all above the distribution of the anesthesia sleep PCI. Most important, I think that since I want to stress sensitivity, this measure is also high in healthy subjects who are anesthetized with ketamine. Ketamine is a dissociative anesthetic, and as I mentioned already, you are fully conscious, you are hallucinating, it's strange, but also completely disconnected from the external environment. And so now we have this reference. Where are vegetative patients? These are the difficult ones because the clinical assessment, we don't trust it. So we need to come up, that's why we need to come up with this sort of complicated procedure. So, most of them are here. These, again, they've been evaluated repetitively. These are chronic vegetative patients with stable diagnosis. Most of them are below the line, are within the distribution of wakefulness, of anesthesia and sleep. But then we find some vegetative state patients who have high complexity. So what do we say now about these patients? We have to accept that somehow they are conscious. Although they are completely disconnected from the external environment, they might not be able to play tennis. They might lack event-related potentials because these measures are not, can be missing in conscious patients, and we have to rely on this distribution and do anything we can to give them a communication channel. This is now the clinical problem and the ethical issue. I won't go further in the clinical issue because Jaco is going to do a much better job than me. And after all, TMS-EEG, it is not very practical to be used at the bedside as it is now. It's bulky and complicated. So I think we should come up with easier measures for screening. I just want to stress that this TMS-EEG is complicated because it was designed to test a specific prediction. And the prediction is that consciousness is tied to a very special kind of information. It's not the information that is in the message. It's not simple entropy on spontaneous activity. So it's not maximum with stochastic processes. This is the information from the intrinsic perspective of the system. It's the one that is generated through causal interaction within a system. So that's why it's difficult to measure, but that's why I think that these experiments are worth it, because the more a theoretical prediction is specific, the more it is informative, whether it is confirmed by data or falsified. So thank you. I'm done.
Very impressive work, thank you. I have two very quick questions. First, how sensitive was the patterns that you observed in EEG to the location of the TMS? And the second is, as far as I understand, you use single pulse TMS. So would you expect the behavior to be maybe different if you use repetitive TMS with different frequencies? So if there was any kind of frequency locking going on, do you think repetitive TMS would reveal that?
So the first question is, we are, there are technical issues there that I don't have time to go through, but we are limited to, with TMS in EEG, to a medial portion, so the areas that are along the midline, so we cannot go to lateral, otherwise we have artifacts. So we probed basically the posterior parietal cortex and the prefrontal, less pre-SMA cortex. And as long as we do this, PCI is high whenever consciousness is there and is low whenever consciousness is lost. Then the rationale for doing single pulse is that we don't want to interfere or change brain activity, which is normally the purpose of repetitive TMS, high-frequency TMS. We want to probe. We use it as a probe. So it is just a perturbation to engage, a subthreshold perturbation to engage causal interactions, and then we try to compress the information generated by this deterministic causal interaction. So, in our case, we don't want to change the brain. We just want to assess its capacity for generating these balance patterns.
One other very quick question. I saw a hand there, and then on the Earlier, you mentioned REM sleep and slow-wave sleep, but your slide here measuring PCI didn't show that. Could you tell us if you have measured PCI in those states?
In REM sleep?
REM sleep and slow-wave sleep?
Oh, yeah. Slow-wave sleep was is the main, was the main part of my talk. That was non-REM sleep stage 4, or N3 now. And you see, if you hit the brain at the subthreshold intensity, but not too hard, you have this local pattern. And the more you increase it, you have this big wave growing in amplitude, but spreading like an oil spot on the cortex. So in no case you have a complex response. This is the typical response of non-REM sleep, N3. I cannot say anything about stage 2. I can say the stage 1, it's more similar. It's in between wakefulness, the complexity of wakefulness, and non-REM sleep. So it's, it would classify as conscious state. And REM sleep is complex. Those were not easy experiments because TMS-EEG is complicated. Unfortunately, spent almost 1 year, like a fisherman waiting for REM. But then the first pass, the subject was waking up, and it was very difficult to have it. So now we have more, actually. But at the time, it was difficult. But it is complex, yes.
Okay, I think we have to leave it there, unfortunately.
So I'm going to focus today mainly on patients because there's a huge clinical challenge when we're facing this in the hospital. And the idea was to create something, to develop something that could be used at a day basis and facing the reality, facing that the patients come in different sorts, and that not all vegetative patients are the same, not all minimally conscious patients are the same, and that there's a huge behavioral overlap among them. So we wanted to create something, to evaluate something that actually beyond the crucial scientific question also tries to solve the very hard clinical question. So I go back over this distinction between conscious content and conscious state. Conscious content is what are we conscious of, when are we seeing something, when are we not seeing it, what are the mechanisms that make this distinction. And conscious state, as Aaron already stated, is what are the necessary mechanisms for us to be conscious, for us to process, for us to incorporate this content. And how do we study these two things? Content, we use traditional paradigms that work with illusions, subliminal images, masking, neglect. Some of you might see the face over there, that we are forced to see things and that may not be there. And the way we evaluate that is using verbal reports. Have you seen this? Did you see the face? You don't see the face? Do you see the duck? Do you see the rabbit? And things like this. And then when it comes to state, then it's a bit more, perhaps a bit more simple, because we want to evaluate in conditions where the subject is responsive versus when the subject is not responsive, when it's not essentially doing anything. So in that case, it's essentially sleep, anesthesia, seizures, and the source of consciousness. And how to contrast? In one case, we try to contrast exactly the same stimulation and see when you see it versus when you don't see it, and see what is the subtle differences between one situation and the other. And when it comes to conscious state, we, unfortunately, in most of the cases, we haven't gone that far as with content, because we tend to contrast perhaps the edges of the spectrum. We tend to contrast when the subject is anesthetized versus when he's awake, or when he's completely sleep, or when he's awake. And the idea that I want to explore is that we should create some similar minimal differential contrast that differentiates minimal differences of subtle differences physiologically or pathologically. And then in general, when we talk about signatures, I think there's two important questions when we're contrasting this, when we're evaluating these two things. First of all, do they share the same time scale? Like, if there's the time scales for the conscious contents, when you see something, when you don't see something, are at the same time scale as the state signatures? Probably not. And second thing is that we want for them to be generalized. We want these signatures, a good signature, to be general, not only inside the content space, so to say. You want a good signature that works with masking, with CFS, with any perturbation, any approaches to give, and you want something that is generalized across. In case of conscious state, as Marcello showed, you want something that is good across conditions that you lose consciousness, for instance, epilepsy, anesthesia, disorders of consciousness, sleep. You want something that works everywhere. And on top of that, ideally, you want to evaluate how they generalize across. Like, is it one that works there, works here, or the opposite? So focusing in my data, I work in disorders of consciousness. Luckily, it's already been introduced the problem that there is a brain injury. In some cases, a person goes into a coma, and then when in this sleep state, similar to sleep state of a coma, you can emerge, and then you go either recover consciousness and you're awake, or you can go into these intermediate states in which you're either vegetative and not responsive whatsoever, or minimally conscious when there is some fluctuating conscious or limited consciousness, but nevertheless it's different to vegetative state. And when it comes to evaluating signatures in this space, I believe that this important thing is to find things that can differentiate between vegetative state and minimally conscious. Okay? It works in this subtle contrast. But on top of that, there has some sort of a gradient when you look from vegetative, say, to minimally conscious, to conscious, and to healthy control. And as we already mentioned, there is an additional problem that there's no gold standard in this, or no ground truth on this problem, because even some vegetative state patients that clinically and behaviorally are completely vegetative, no response whatsoever, they have covert awareness. Like when you put them on a scanner and you ask them to either play tennis or to navigate the house, they show these willful modulations of their activity. And not having a ground truth is an additional problem. So we have to keep that in mind. So when I say that facing the real clinical challenge is a big challenge, I mentioned the fact that we are working with, in the hospital, in the Pitié-Salpêtrière in Paris, and many, many patients that come for evaluation of their conscious state every week. And we focus our analysis on a data set of patients between 2008 and 2010. We have more patients right now. But the idea is that in this large sample of patients, if you look at the behavioral score, this is the CRS score, so it's a behavioral evaluation of the patients, you see that there is some overlap between BS and MCS patients. That the behavior is hard to distinguish in some cases. And you want something that works even though you have this overlap, because there's something that differs between these BS and MCS patients. And you want something that essentially shows this gradient when you look at patients that were BS and MCS and they're no longer there, that they are conscious, that you can talk to them even though they have important brain injury, but you're sure they're conscious. And the evaluation that we do is using high-density EEG, and we use a 20-minute editorial paradigm, which we use not only to produce ERPs and to evaluate those ERPs, but as well to evaluate the ongoing activity in some sections of the paradigm. All right. So what type of signatures will we use? Okay, the idea that we have is to derive signatures from the present theories. And Marcello already mentioned one, which is very important, the fact that one of the predictions is you want to have some complex activity in the brain, both evoked and ongoing, but as Marcello mentioned, probably even more evoked. But as well, there are other predictions, like the fact that the sharing of information across brain areas is important, and that there's some transferring of information in particular spectral bands is also important, and things like this. So we had this approach to evaluate several measures at the same time using the same paradigm. So we have a large data set, a large amount of measures evaluated, and we put all together in the same analysis. But before going into this comparison of a large scale of measures, I want to measure one signature that we thought was going to be important. Is the idea that, and it is shared across theories, is that the idea that for a brain to be conscious, in a conscious state, to be able to process data consciously, it had to be able to share information across brain regions. And on top of that, the distance between the regions is also important. It's not only the fact that they can share lots amounts of information, but the whole brain can do that. And interestingly, there's many, I'm going to show Joe just one study, but there's many evidence that conscious perception is associated with increased functional sharing of information, okay, or correlation. So there's this idea that you can extrapolate some results from the content part of consciousness to the state. So if something it's working in content, it should work in state as well. So this is one study, just to give one example. There are many out there that shows that when you do a masking paradigm and you contrast seen versus unseen, or mask versus not mask, you see that clearly there is changes in connectivity that can mark the scene situation. So how do you measure that in patients that have lots of artifacts that move, that are very difficult, that the activity is hard the signal to noise is very low? So we had to develop a new measure that essentially can somehow reduce the space of information and to evaluate the transfer of information or non-trivial information. So we developed this measure. It's called the weighted symbolic mutual information. I'm going to describe it a little bit more, but The idea is that we do a transformation of the time series into a space that is smaller in terms of dimensions, and that we evaluate the information sharing from the joint probability of those symbols. I'm going to explain this a little bit more, but the idea here is that you can somehow, that continuous signal transform it into a subset of symbols that essentially capture the dynamics in the signal, okay? Essentially, if the signal is going down, or it's going up, or it's doing a sort of a small oscillation, and you can do this each individually in each channel, and then after estimating the probabilities for each of the symbols in each of the channels, somehow you can estimate the jump probabilities, so to speak. In that example over there, you can see that the symbol A in the top signal, in the X, is always associated to the symbol B on the signal of the point Y, and that's the joint probability. So if something is always predictable, that each symbol should be associated to only one symbol on the other side, but that never happens, of course. So on top of that, there's a difficulty that using EEG, there are limitations for volume conduction and from common sources that can be represented. So we did a small correction to this measure, as we call the weights, that essentially disregard any trivial correlation between symbols. And the idea here is that you're not only disregarding associations that are due to physical properties of the electrical activity in the brain, but as well things that are reflecting common sources. So you essentially want to see communication between two locations. There is real communication, and not a reflection of something that is not. So when we evaluated this measure for the patient and this large, so for vegetative state patients, minimally conscious patients, and conscious patients, we see these two things that we expected to see. First of all, we see a huge difference when we evaluate the amount of information shared in each location to the rest of the brain between BS and MCS, okay? And then you see a gradient when you look at conscious patients and healthy controls. And then you can as well look at all individual connection between different areas, and as well there is a huge difference when you jump from vegetative state to minimally conscious state. And of course, the gradient continues for other conditions. And importantly, when I talk about generalization, like today I'm not going to show generalization to other conditions of loss of consciousness, but inside the disorders of consciousness, it's important that this result generalizes. And how do you generalize it? Well, you want to be generalized across etiologies. So you can be in a vegetative state or minimally conscious state because of different etiologies, and you want something that essentially shows a similar difference between BS and MCS patients across etiologies. And you want to have something similar across chronology. If the patient is acute, if it's been 50, 60 days since the injury, or if it's chronic, you want to have something that works in all cases. So we essentially be showing that this measure can discriminate for any etiology in a similar manner, and for different delays in a similar manner. And then it comes the other side of the arrow. Like we had this prediction as well that the longer distances were important. So if you essentially evaluate your measure using only distances below a certain threshold, let's say below 10 centimeters, you find that there is no discrimination. But if you go into longer distances, you can see that the discrimination is stronger. So this somehow says that these long distances are important in the terms of information sharing when you want to discriminate BS versus MCS patients. So that's the story I want to tell about one signature, but the idea is that can we go beyond a single signature? Can we compare and combine several measures? And like I said, there are several signatures proposed. So there are the ERPs that reflect the learning of a rule, sustaining of information, and things like this that are important. We have the spectral estimations that they have no strong theoretical background, but they work very well, so we want to evaluate them as well. You have the complexity that Marcello already mentioned that is crucial, and we have the connectivity. So can we compare the performance? Can we carry some sort of quantification to see what works best and what doesn't work? Do they carry independent information? Can we see if can we evaluate even better the patient by combining the information from several measures? And that was the last question. Can we optimally combine them? So how do you do this comparison? So we use this method. It's called the receiver operation characteristic curve, and you estimate the area on the curve. I'm going to quite quickly introduce it, just if I'm pretty sure everybody knows it, but just in case. What you see there is each single point is one patient. It's a recording from one patient. And you can draw a criterion, and you move that criterion. And with that, you can create, with the true positive rates and the false positive rate, the ROC curve. And you can measure the area under the curve or above the curve. And that area is somehow a quantification of how good your measure is. If your end of curve is 1, it means that you can completely separate the patients using this measure. And if it's 0.5, it's essentially noise. So there's no way you can distinguish one thing from the other. So those three comparisons, let's say BS versus MCS, BS versus CS, and MCS versus CS, you can, from the areas under the curve, put it as a single point on a space that essentially show that you can distinguish the three comparisons in a different manner. For instance, the red dot says that you can read them very small. You can with a 0.6 value, you can distinguish BS from MCS, MCS from CS a little bit better, and BS from CS even more. Okay. So when I put all of this together with 92 measures that we evaluated, that's how it looks. So there's plenty of data. There's plenty of measures that work. Some work better, some don't work. And so there's a story behind each one of those. I don't have the time to go over those. But the idea is that in general, for the big ones, the ERPs, some of them work. And that's interesting because you can see this gradient, the spectral measures as well, the complexity measures. We have some basic complexity measures, but as well something similar to what Marcello does, the measuring the Lempel-Sieve complexity with the response to the auditory activity, and that works as well, and the connectivity thing that I showed you before. So the next question is do we the average or the fluctuations in time? Do these carry the same information or not? We have the opportunity to evaluate the patient during 20 minutes and to have several measures or several trials of the same measure, so to speak, 800 evaluations of the alpha power in a 2-second window. So do the fluctuation of this marker, of this signature, carries independent information to the mean across trial, and can we, maybe one works and not the other, but like few hypotheses that say, in this case, both the mean and the average are differentiating. In this case, the same thing, but in an opposite way, or here, only the variations show something interesting and not the mean. So what I did is essentially evaluate the discrimination of power for the mean and the variance, and you have this two-dimensional space in which you see all the measures to see if they discriminate in one condition and the other. So first of all, you have measures that can discriminate both in mean and in variance. For instance, all the spectral measures, alpha, theta, beta. As well, you can see that there are measures that show an opposite trend, for instance, opposite trend for mean. For instance, delta has higher value for VS as compared to MCS, but you have more fluctuation in the conscious patients as compared to the vegetative patients, which is interesting. You see, not having high in delta or low delta is not enough. You have to have low delta, but as well fluctuations, showing that this stream of consciousness is important and the changes are important. And even more interestingly, I think, here we have all complexity measures. We have the permutation entropy, the Lempel-Sieve complexity of the data. And here what we see is that you need to have higher complexity, but it has to be less variable or more stable in time. So you need to be complex, but as well as stable in time with that complexity. And the two other questions that I pointed out is, more is better. Can we combine the information using multivariate analysis? So what you see there is using your best single measure, cross-validating, because you need to do that, you have something like a 71, 72% AUC discrimination. But when you put all the measures together, you go up to 80% of discrimination in this critical BS-MCS comparison. If you go to the other comparison, that's even better, about 90%. And what happens to the individual subjects? Let's say we have all the vegetative state patients clinically diagnosed, and then we ask the system where are they where we would put them. So in most of the cases we put them in the same condition, but in some cases we don't. And there's a problem of the ground truth that we don't have. So the only thing we can do is to see the prognosis. What happened to these patients? So what I can tell you is that out of these patients, when you look at the recovery rate, only 20% of the vegetative clinically, vegetative for the EEG recover, while the ones that are not vegetative for the system, the rate of recovery is twice as much, showing that either they are in a better curve, in a better situation, or they were conscious at the moment of the evaluation. So just to wrap up, it's important to focus on the clinical question. When you look at want to use these signatures, you have to stay in this clinical comparison. What I'm showing there is the number of subjects you evaluated as compared to previous studies that were in the field evaluating EEG measures in dog patients. Second, that there are many measures that actually work. The long distance information sharing, the late ERPs, the complexity, the spectral power. Third, that there is partial independent information in mean and variance, and this is important as well for our theories of consciousness. We have to somehow explain that or incorporate it or evaluate it in the scope of our theories. And finally, that these markers can be compared, but more important, combined. So this is also important for theory because we want to know whether we are seeing different aspects of the same phenomena or different phenomena that are necessary for consciousness. So with that, I finish, and I want to thank Jeremy King, which was a PhD student of Stan, and we was part of all of this work, and very bright student, and both Lionel and Stanislas that I had the pleasure to work with. Thank you very much.
Thank you, Jaco. So we'll take just 2 questions while Anil is setting up. Any questions for Jaco?
So the massive comparison is done with the same paradigm, and you evaluate ERPs. No. So in the paradigm, we can evaluate both the ERPs and the resting state because there's space in the paradigm to evaluate both. But it's in the same patient and in the same session, essentially. That's the logic. So in some cases, for instance, for the connectivity measure that I showed in the current biology paper, we show that we have similar results with or without the perturbation. Slightly different, but essentially showing the same differentiation. I cannot say the same thing for all the markers because we haven't tested all the markers in the 2 situations. But for that in particular, I can tell you yes, that is important. And for us, it's important to put it all in the same paradigm because the ERPs, even more when you do the coding of the ERPs, are very good or as good as the connectivity measures to distinguish. And probably they carry independent information because when you combine them, you get a better estimation.
Okay, let's thank Jaco once again.
Oops, it's already started.
started by itself. Okay, so I want to thank my fellow symposiasts first, actually, because they've already presented such a wealth of beautiful data about measuring consciousness, especially in clinical conditions. The best has definitely already happened in that regard. I'm sort of here, I suppose, to return to some of the context at the beginning and ask some sort of maybe probing questions about what it means. But I also want to present a little bit of data analysis from our own lab, and these are Adam, Michael, Lionel, and Georgina who've done some of this work. And this is not going to say that we have the best ways of discriminating these conscious states. Really, the analyses I want to present are going to be because maybe they're really showing that they're taking a different approach, and in a way it's why they don't work quite so well that I think might be theoretically of interest when we get to the discussion. So this is a backwards talk. We've already had plenty of background introduction, so I'm going to go straight into the data, and then at the end come back to the introduction, which will be the sort of wrap-up. There's a precedent for this in sort of certain films called reverse chronology, so I'm on safe ground here. So the data part is like this. I'm going to talk a little bit about complexity-based measures of conscious level based on some intracranially recorded EEG data that comes from Lino Nobili and Marcello Massimini's lab. And then I want to ask us a question which hasn't been addressed yet, which is how do we actually predict and detect transitions in conscious level? I think this is also a clinically and theoretically very important question that's not come up in this symposium, at least so far. The measures I'll be focusing on have something in common, which is that they're all to do with complexity and directed functional connectivity, causal interactions between system elements, something I've been interested in for a very long time. So this is the kind of data we've been looking at. This, again, comes from Marcello and Lino Nobili. This is spontaneous resting state intracranial EEG, so there's not even any beep, beep, beep permutation here. This is just the data during resting state, during sleeping and waking. So that's all we have. These are pre-surgical epileptic patients, so a different kind of patient group. What we did was similar to Jaco. We applied a whole battery of distinct measures to 10-second non-overlapping windows of this data. We had just 9 subjects and 18 electrodes, so as you can see, an impoverished data set compared to the kind of stuff you've been hearing before, but still interesting to find stuff out about. So there's various different measures we look at, power bands and Lempel-Ziv complexity I'll come back to. Coalition entropy is a very interesting measure. This is really looking at how varied the ensembles of synchronized channels are over time. So it's a different way of looking at complexity again. Causal density is something I've been interested for a while. I'll explain it. We look at phi and various control measures. Lempel-Ziv complexity has been introduced basically without going into the details here. We're just looking at how compressible a signal is. Now, we can get to this in discussion, but I'm using it in a different way from Marcello. Here, I'm just looking at how compressible the raw data is, not how compressible the deterministic response to a series of pulses are. So this is something where we really need to make sure we're careful about, because people can use the same terms like complexity or even the same algorithms like Lempel-Ziv, and it means completely different things. Coalition entropy I just measured looks at the variability or variance of ensembles of functionally connected channels over time. So it's looking at how coalitions of ensembles change over time. Causal density is something I've been sort of trying to investigate in real data for a very long time. It's quite hard to do. What it really does, it takes this idea of complexity again and says that a system asks what the density of causal interactions, not really surprising given the name, are among elements of a system. The key point about this, I use Granger causality to measure it, the key point about this is it's only high when all parts of a system are doing something that's different, so they contribute potentially new predictive information, yet the system as a whole is integrated, so that the potentially useful predictive information is in fact predicted for different parts of the system. So it really operationalizes this idea of high levels of simultaneous integration and differentiation in a system's dynamics. So just quickly, some of the results. When we look at these sleep versus wake comparisons, what we see very clearly is that both coalition entropy and Lempel-Ziv complexity show dramatic decreases on loss of consciousness in sleep. This is something we see. They both recover, quite interestingly, they both recover in later non-REM sleep to a little extent. One of the other interesting features of this analysis is that when we look at it I'm sorry about these figures are all basically have been produced in the last few days, so they're not prettified. But if we look in different distinct frequency bands and do this analysis, we don't find it to be as informative. So we get the best picture when applying these complexity measures, at least Lempel-Ziv and coalition entropy, looking at the broadband signal, which gives a hint that it's not just a reflection of changes in spectral power. The same is slightly different when we look at causal density. So now these again, I don't expect you to sort of look at all the dots there and figure what's going out. This is more just a reference, so it's there. This is looking at causal density in different frequency bands, comparing waking against sleep. This is actually a very difficult analysis to do Kraninger causality in the spectral domain conditioned on many different things. That's something we've only been able to do in the last few months. And what we see here, again, is again quite reliable signatures, but it depends on which frequency band you're in. So global causal density is higher in the delta band during sleep than the wake, but higher in the alpha and beta gamma bands during wake than in sleep. And what we're looking at here is really the amount of causal interactions among the different electrodes, different channels in each patient. We're using longer time windows than have been used in these previous analyses as well. So if we look at this is another AUC curve of the sort that Jaco had, what we see is that, again, different measures have different sorts of discriminatory performance. And the one thing that I want to point out is that quite often they correlate. So if causal density in, say, a frequency band does well, so does spectral power in that frequency band. And that poses, I think, a challenge for us to figure out. We have these sort of theoretically driven measures which can be quite complicated to develop and apply. And we need to be very careful to figure out what that is giving us, pragmatically, above and beyond more simple measures that might serve as more empirically sensitive indicators. So that's something to come back to later on. The last bit of data in this part of it is we're also fortunate to have from Lina Nobili and Marcello data from a whole night. So this is 9 hours of continuous IEEG recording from a patient who entered repeated states of, occasionally woke up, but had repeated REM, REM sleep, dreaming episodes, but sleep scored the whole night. And we can again see that Lempel-Ziv and coalition entry both jump up to quite stable and quite high levels during these episodes during the night. And having, and again, there are also changes in frequency bands. These are just the different frequency bands. Having this rich data over a whole night allows us to correlate, look at how these different measures actually correlate. And again, I'm not going to interpret the whole of this data, but you can see that there's a large mess on the off-diagonal of medium to high correlations. So we want to dig into this a bit more to really understand which measures are saying something that's distinctive and different from which other measures. And one of the things that's immediately apparent also, just these arrows, what you can see there is, although causal density does correlate with power in the corresponding frequency bands, the correlation is not great, so there's something additional going on that's being measured. So the interim summary for this part is that there's been a detailed study of complexity on this continuous, spontaneous data, so not banging on the brain, not beeping. And we see changes in various complexity measures, which are often, for some measures, more apparent in the broadband signal, and for other measures, more apparent in frequency-specific signals. So the second short data part, what's a modeling part really, is to address this question of transitions in consciousness. So it's important to be able to detect not only levels, but also these transitions. For example, the onset of anesthesia or the onset of an absence epileptic seizure. We might want to see what in the brain is happening prior to these events taking place, typical EEG signal from anesthesia. It's been very, very hard to predict seizure onset. This is, of course, an outstanding problem. One model emerging from statistical physics that's relevant to this problem, this is called the Ising model. It's a canonical model in statistical physics where you have a grid of elements that flip up and down in their spins, and depending on the computational temperature of the system, it goes through a phase transition where all the elements settle into a particular state. This has been used to model phase transitions from liquids to gases to solids, all kinds of different things, superconductivity and magnetism, all these kinds of things. And it's been interesting that although this model has been studied for more than 50 years, only last year, in collaboration with an Australian group here actually, Lionel Barnett, one of my mathematician postdocs, found a way to predict the onset of a phase transition in this system. There have been many measures that have been sensitive to when a phase transition is actually happening, but we have a measure based on information flow density that for the first time predicts when a phase transition is about to happen in this very well-studied system that's nothing like the brain. I'll make that very clear. So now it's also quite a subtle effect. pointer's not working very well, but well, you can see basically right on the right there is a peak, which is a peak that's not at the phase transition. That's the key point. Actually, this caused some interesting media coverage that mathematicians have a crystal ball about to predict when disasters are going to happen. And one radio interview asked me if it could predict when their boiler was about to break down, which was a strange thing to claim. So what we're doing with this approach is trying now to go towards the data step by step, and we're still in the realm of models here by looking at detailed cortical network models. So this is work with Thomas Novotny and David Samu, where we're looking at very high-resolution diffusion tensor imaging models, which we animate at this point using simple Ising model dynamics, just flipping states. And we want to see whether we can predict phase transitions when we impose these dynamics on a cortical topology. And the short answer is yes, we can, but only so far in specific situations. So there's a peak shift here. You can see the red on the right. The red is peaking in a different place from the blue. But it depends on exactly properties of the network, which I don't have time to go into. But the thing here I'm just gesturing towards is there's another theory-driven way based on information flow density, getting at a different question now, which is phase transitions relevant to distinct transitions in conscious level. So in interest of time, I'll skip that. And now, really, it's back to the context part. And this is, I think, where I take a little bit more 5 minutes here, just to return us to where we were at the beginning. Now that we've seen, especially from the other speakers, some beautiful data that really, I think, is revolutionizing things in being able to detect very fine-grained distinctions in conscious level. But we return to the idea of what we are trying to do when we want to quantify the unquantifiable. And you can think there are really two objectives. There is the pragmatic objective in the clinical setting, and there's the explanatory objective. This is our current president back in 1996, I think, with his says on the back there, would be easier if we had a consciousness meter. And where's the thing? The history of science, of course, has always strongly indicated that in order to understand a natural phenomenon, we need some way of measuring it. This was the case when we tried to understand the mechanistic basis of heat a few centuries ago. So we have these two different objectives, and the question to think about is the extent to which they align. So pragmatic approaches, just to summarize the kinds of things we're trying to do here, is really, for example, distinguish minimally conscious state from vegetative state. That's one thing. And we've seen some very great examples of that. So these pragmatic measures aim to have high sensitivity, high specificity. A measure that has both of those, probably in Aaron's terminology, will be a good signature. And of course, there's clinical applicability. Can these things be applied at the bedside? And these are just the recent papers from the other speakers showing dramatic progress in these different directions. Signature. One can think also in the pragmatic line of a hierarchy of objectives, running from diagnosis, which state someone's into, prognosis, are they going to recover or not, communication, can we actually use these channels to be able to communicate with a patient and a disorder of consciousness, and finally maybe treatment. And then there are different approaches to these different objectives. Passive, do we just look at the data that's coming out of the brain of these people? Perturbational, whether it's mild, using auditory stimulation, or strong, using a TMS pulse. Or active, like the Adrian Owen paradigm of asking questions and recording brain responses. And so different kinds of measures as well. We have regional measures where we will take maybe activity or the properties of a single brain region to be indicative of these different levels or states of consciousness, to information sharing, which Jaakko talked about, and then to information transfer, which is evident both in Marcello's work on the PCI and some of the stuff that we're doing using Granger causality. These things can be arranged in a table, if you like. You can sort of ask, well, here are the different things you might try to do in a pragmatic setting, and here are the different approaches that we can apply. So you wouldn't, for example, be able to use a passive approach to open a communication channel with a patient. Just some examples to sum up where we've come from. This is sort of mild perturbational approach from Jaakko using the auditory stimulation. We've seen the work from Marcello's lab on causal measures, and then the active approach with Adrian Owen's Imagine Playing Tennis stuff. And then we can look at regional data. So there's some data showing there are quite specific regional changes differentiating levels of consciousness, information sharing, and finally, again, information transfer or information flow in a causal sense. So that's the pragmatic approach. The explanatory approach is sort of starts from the idea that having a dependable measure of consciousness is vital for a mature science of consciousness. And it's him again appearing twice. Sorry about that, David. And this is really the idea that we start from the phenomenology in this case. What is it like to have a conscious experience? We've heard a lot about this. One way to think about it, which is very much in line with Giulio's work, is that conscious experiences are highly integrated and highly differentiated. They are, in this specific sense, complex. What is the kind of mechanism that might support this? Well, it's a little bit like the behavior of an orchestra, but without a conductor. That's a metaphor that can often be used. And of course, then we can have measures that start from this and try to get down. This is the approach we've been taking a little bit in my group with approximations to integrated information. I forgot to show, actually, in our analysis of the sleep-wake data, we tried this approximation to phi, and it wasn't very good. Now, this could be because it's not a very good approximation. And causal density is another thing that starts from the phenomenology, tries to go down. So what's the point of this theory if measures like causal density and our approximation to phi don't do as well as something simpler? Well, I guess the idea, the thought is, and this is something we discussed, is that the extent to which a measure along this way, the fidelity to some underlying theory increases, we might expect that measure to, in virtue of that, have greater empirical purchase. Maybe that's the implicit assumption running through a lot of the work we've heard about today. And maybe as we go up this diagonal, we hope we do, we'll also transition from measures that are sensitive to region, to measures that are sensitive to functional, to measures that are sensitive to causal circuits that actually underpin specific cognitive and conscious functions. Of course, at the end, we will have causal density or something like that will work, but probably not yet. Another way to ask the question is, what's the point, not what's the point of theory, but where's the point of theory? We have a number of different theoretical perspectives. We have a number of different measures. Do these different measures drive a wedge between the different types of theories that we have? And at the moment, it's probably fair to say that they don't really do that. We have a number of interesting measures, but they are all compatible with most of the theories that we have currently. They may be inspired by different theories, but they may not drive a wedge between them. So just to sum the thought up again, I guess the idea is we want measures that are both sensitive. So by sensitivity, we minimize false negatives. So we don't miss people out. Okay, yeah, I'm almost done. We don't miss people out. And sensitivity, a measure that's sensitive implies we're really looking at those parts of the underlying mechanism that might be considered necessary for a particular phenomenon. We also are interested in specificity, and by specificity, this minimizes the false positives. So that means we don't include people by mistake for a particular phenomenon. Now, from a clinical point of view, we might want to emphasize sensitivity over specificity, as was mentioned earlier. But when we look at specificity, then we're also looking really at those mechanisms that might be sufficient for a particular phenomenon. So then the thought is, by combining necessity and sufficiency, we're really moving beyond just what is a correlation towards an explanation, because we're getting at mechanisms that have both necessity and sufficiency for a particular phenomenon. So then this leads to the question, maybe there is then a reason to think that a signature of consciousness is similar to what one can call an explanatory correlate, something that doesn't just correlate, but also explains the phenomenon that we're interested in. A cautionary note on this, though, is that maybe there is not just one thing we're trying to explain. Another implicit assumption is that we might arrive through some combination of measures or some specific measure, the most sensitive way of making the distinction we want to make. But what is that distinction that we want to make? Is there a single axis or dimension on which consciousness can be considered, or even conscious level can be considered? Well, of course, maybe, but then if we think of consciousness as a constellation concept, it involves all kinds of different things: a first-person perspective, embodied selfhood, emotion, mood, a narrative, self, widespread access. There is no necessity, there's no a priori reason why these different aspects of consciousness need to depend on the same underlying mechanism. The hope is that there is some common process and that these measures tap into that common process. But again, that's not something that take for granted necessarily. So I'll finish just by putting Aaron's tough questions back up on the projector. That's where we started. And so these are, again, how do we know whether a given signature is specific to consciousness rather than just a general signature of brain function? And I suppose appeal to theory is some answer to that. If your signature is predicted by more than one theory, is it meaningful to say that it's theory-driven? Well, here we have the distinction again between being inspired by a theory and testing specific theories against each other. And what do we learn about consciousness from the fact that seemingly different metrics cohere in specific applications? This could be very good, it could show we're onto something, or it could be very bad in the sense that maybe some rather trivial factor is underlying all the different things that we're looking at. And then some other things we might want to return to is the word complexity keeps coming up again and again in lots of these discussions, and it has many different specific meanings. Even something relatively well-defined like Lempel-Ziv complexity has different meanings in the different applications we've seen today. And finally, does fidelity to a theory imply that you will have a better signature in terms of specificity and sensitivity, even if your theory is right? So I'm going to leave those questions up there, and I think in the interest of time, it would be a good idea if we just have questions open to the whole symposium now. So if we all, the speakers all come back up, and then I think we can have a few minutes for general questions for everybody. Thank you. So let me field some of the questions for everybody.